Welcome to The Pod, a podcast for women in healthcare leadership, a heartfelt space where women executives in healthcare and their allies unite to support and uplift each other with personal stories that inspire positive change, nurture optimistic mindsets, and celebrate diverse perspectives. I'm your host, Dr. Kristen Woods. The ultimate measure of a man is not where he stands in moments of comfort and convenience, but where he stands at times of challenge and controversy. Dr. Martin Luther King Jr. reminds us that the courage to lead isn't about having all the answers. It's about being willing to ask the difficult questions that others won't, and then to act on what we discover, even when it challenges the way we've always done things. Today, we're speaking with a physician and a leader who's been willing to ask the hard questions, listen carefully for answers, and take bold steps toward transformation in a health system that is badly broken. Dr. Cathy Faulds is a leading expert in primary care delivery. As a family physician who is also board certified in palliative and hospice medicine, she currently serves as a palliative care physician with St. Joseph's Health Centre in Ontario and as a staff family physician at London Health Sciences Centre, while also wearing the hats of clinical professor at Western University and as faculty at CPEP, where she teaches ethical remediation. Dr. Faulds chairs the Ontario Medical Association and ARGI.Inc. boards of directors, adding to her long-standing history of board participation, which has included the Ontario College of Family Physicians, the College of Family Physicians of Canada, Thames Valley Board of Research, Participation House, and the University of Western Ontario Foundation Board. Dr. Faulds has actively participated on numerous committees at Health Quality Ontario, promoting quality improvement and developing meaningful primary care metrics. She's been on the technical committee of Accreditation Canada to co-write primary care standards, and she served as co-chair of Family Medicine Alliance in Ontario. She's been a College of Physician and Surgeons of Ontario investigator, and adding to her long list of credentials, Dr. Faulds is also an executive coach and has received her registered corporate coach designation through the Worldwide Association of Business Coaches. Welcome to the pod, Cathy.
Thank you so much, Kristen. It's an honor and a privilege to be here this morning with you.
Well, we're excited to have this conversation, or I'm really excited to have this conversation. So let's jump right into the questions. So the first question I have, Cathy, is you've been board chair at the Ontario Medical Association during a particularly challenging time for healthcare. What made you realize that physicians need to lead differently than we have in the past?
Yeah, it's a great question, Kristen. And it's really become clear to me, especially during, I would say, the most difficult phase was the pandemic, that physicians remain one of the most trusted healthcare providers in society. But trust it's not enough. It's a privilege, but it's not enough. It's a real responsibility, and we can't simply use it to critique a system in crisis. We have to show up, and we have to show up with humility, and we have to show up with the courage at the tables where the decisions are being made. And once we're there, we need to really lead with solutions. And so it's one thing to declare the system's in crisis. It's another to come to the table with solutions. And someone yesterday actually said to me that as physicians, we need to communicate and leaders so that others can listen and can really hear us. And I think that's a really important skill. So calling out the state of crisis has really been necessary. And we had to validate what healthcare workers and what patients were experiencing. And we had to really galvanize that political attention to the healthcare system. But naming the problem, as I said, that's not enough. It's not enough for change. So when we need to transform something, we're successful, I think, when we pair that truth-telling with compassionate leadership. And so It's leadership for me that's rooted in integrity. It's rooted in kindness and in empathy. And the cost of not leading with compassionate leadership is staggering. So I'd love to quote Kaiser Permanente. I realize they're US, but they estimate that burnout and toxic workplace, a workplace that's not led by compassionate leadership and a culture that isn't steeped in empathy, costs the US healthcare system $4.6 billion annually. And the literature's staggering. I could go on, but I think I'll just give that one figure because follow the money is something that I have learned really well at the OMA. But beyond the dollar, it's that erosion of cost is in meaning. It's in the meaning of the work that we do. It's in the morale of our colleagues and our patients. And it's in safety. So, the literature, and you know it as well as I do, being in leadership, that the safety of our surgical teams depends upon it. And so at a time when we're all talking about burnout, we're talking about moral injury, compassionate leadership is the way forward. And the other thing that I noticed is that in crises, and there's been lots in my career, but the pandemic is the one that I really think about most recently. The real leaders aren't the ones that are the most senior. I'm sorry to say that out loud. And they're not the ones that are the most vocal. They really weren't. They're the ones who were present, and they were really principled. And they were people first. They were about relationships. And it's that kind of leadership that our profession, but more importantly, our system. And I'm going to be a user of the system sooner than you are. And I just want the system to be really viable and to be future forward and to have that compassionate leadership there going forward. So, how do we lead differently? I think that is different. And I know some of the other questions you're going to ask me are really about how is that different than what we're already doing? And many of my colleagues lead with compassionate leadership. But I think that needs to be the norm and the culture of our system.
I love how you've synthesized this. And I want to comment on two parts. There's a lot of meat just in what you gave us. But number one, I want to comment on the compassionate leadership that you talked about. And you talked about the return on investment of compassionate leadership. I want to mention too, it costs us nothing. It costs us zero to lead with compassion. So the ROI is infinite when you think about what it costs. And the second thing I want to emphasize is the search image of what a leader is. And part of changing our recognizing leaders that are quieter, that lead but with being fully present, with listening, with sharing, being compassionate, is changing our search image of what we typically think of as a CEO. And I'm seeing that a lot in leadership development literature, organizational development literature, and that need to build trust among teams. So I think you bring up, those are just two of the points that really stood out to me in your response.
Yeah, great points. I like the fact that it's free to be kind.
Yes.
Yeah.
So one of the things I wanted to ask about is physicians often, they work on teams, but they also have this individual contributor mindset. Mm-hmm. But you and I have talked about the value of collective impact when you see physicians taking a leading role in transformation. Can you share a specific moment or story when you thought, we just can't keep doing things the old way?
Yeah. I think that there's many. I was thinking about, what's shaped me to get me in this mindset. And it goes back to the bedside. It goes back to my colleagues, my peers, and the nurses that I work with in the community. And one of the themes that kept coming up was I've stopped making suggestions. No one listens anymore. And it was around improvements in home care. And my palliative care colleagues said, I'm tired of putting in suggestions. The nurses said, I'm tired of telling my supervisor. And I just felt the weight of that silence. When people that are very skilled and very compassionate and very empathetic are silenced or silence themselves with almost an apathy, that was the moment that it really said to me, it's broken. It's broken. We've got something here in our culture that's broken. So I know that their insight is essential to patient safety. I know it's essential to workflow, to quality. And whether it was being dismissed or ignored, or people at different levels of management and leadership were just overwhelmed for whatever reason. This isn't a blame. This is an observation. And it's that quiet apathy that's just seeping into our workforce. And I think that's what's contributed to the moral distress that we see in our healthcare workers today. And it's not because they don't care. It genuinely isn't. They truly care, but it's because they felt that they didn't matter. So what they had to say didn't matter. So I then said, how does leadership happen? We don't need more top-down directives. We just top-down directives in 40 years of my practice, some of them work. Paternalism works as a doctor-patient relationship. There's a time and place for it. But if we really put on our physician hats and we say a deliberative model, an interpretive model of being a physician is what we strive for, to align treatments and around patient goals, why wouldn't we take that approach as we're leading people? So I always say leadership isn't about rank. So I love the introduction and the titles, but it's not the titles where I sometimes do the most important work that I feel I do, or the work that I'm most proud of. It's about the responsibility, and it's about the accountability that I take, but it's mostly about the responsibility. So structures that end up being co-created, co-owned. So if I have ownership in something, wow, I'm going to take accountability and responsibility. It's where physicians, nurses, allied health professionals, even patients have an important seat at the table in shaping our structure and our system. And that to me is what I kind of think of as collective impact. So prioritization, if we prioritize and we root what we do in collaboration and dignity. Right? And I guess that's the palliative care doc in me, wanting that dignity to be there, because the only kind of system that truly is here to serve, and we're here to serve others. That's why we get into healthcare, quite frankly. The patient's at the center of everything that we do. It's only built by those who provide and receive care. And we have to do that together. So that's a very kind of holistic way to look at collective impact, but it's really kind of what said to me, we can't do this the old way. We can't have all top down. We have to work together, and collectively we'll accomplish a whole lot more than we do alone. And there's some great expressions that say, if you want to go fast, go alone. If you want to really make impact, then go together, get a team and go together collectively.
Love that saying. And I appreciate your sharing that. And sometimes my husband and I, and Paul, we talk about sometimes it's both and, just like you said, there's a time and place for paternalistic care in an emergency, et cetera. And there are times where we have to look at doing bits alone, but that collective piece is really, it provides us that energy and momentum when times get really tough to keep going when we have a collective goal. So I like how you've shared that.
No. And I think there's sorry, Kristen, there's another expression that, was a book back in, the 90s when I was struggling being a mother and 2 young children, a husband as a physician, sandwiched in between caring for elder parents. and practicing. And there was a book out, How Does She Do It All? And it reminded me, it was kind of back there in the 90s that I also said to myself, she doesn't. She doesn't do it all. She learns how to delegate, not abdicate, but delegate. She learns how to work in a team, whether that's a team in her home, whether that's a team in the office, the community, the hospital. And so I think that really shaped me and became a philosophy of I can't do it all. I can't do it all.
That's right. Thank you for adding that. It's so important too. Many of our listeners are women leaders, women physicians, and that's a common social pressure to feel like you have to do it all. And so you remind us again that you don't, and you don't have to do it alone. You can delegate it out to help.
Yeah, why do people say leadership's lonely? I want to write a book that says that's a fallacy. My leadership isn't lonely. I'm on the phone. I'm on Zoom this morning talking to you about leadership. I don't hesitate to text or to call or to lean on. Or I said to someone one day, my Rolodex is huge because it needs to be. The roles that I've done and the clinical roles, the leadership roles, the roll your sleeve up roles of volunteerism. You need a massive Rolodex. You don't have to be lonely. And so I think that's the other. Maybe that's a new book that you could write. I'm not a book writer, but leadership does not have to be lonely.
Well, I love how you just delegated the writing of the book to me.
Yes, exactly.
I'm a great
delegator.
I'm not an author yet, so maybe this is a joint venture. We'll have to see.
Yeah.
The other question I wanted to get your insights on is, you said to me recently that we have to start leading with foresight rather than being reactive, and that too often in healthcare we've been reactive. Can you give an example from your own experience about that?
Yeah, for sure. I think that foresight for me means, and I grew up in a hockey family, so it's, going where the puck is going. It's knowing where the system is going. It's stepping up to kind of guide the evolution of the system rather than resisting it. So, I think of the things recently, and I've been watching as a board chair, especially of the OMA, but also of RG and of Participation House, that, AI tools and wearables and virtual care, self-diagnosis platforms, the DIY of your diagnosis, team-based care models, which are really new for a lot of physicians to work in, expanded scopes of practice of allied health professionals, delegated responsibility. Elder care. That's the number one thing that we're all dealing with as we go to work. It's not childcare now, it's elder care. Increased complexity of care. I think of all of these things that have landed on the board tables. And they're not hypothetical, they're real, they're here, they're already here. And we can either fear these shifts, we can either feel threatened by them, or we can help to shape them into something that's really ethical, something that's effective, and equitable, I would say equitable. So as a board chair, just fostering that foresight and governance has been one of my priorities. And been working on that now for 3 years at the OMA. We have to be ready for the conversations that'll define the next decade of healthcare. We just have to be. And there are conversations about autonomy, equity, access. The government. It's not just the government, though. I, as a resident, want access to good healthcare. And sustainability in the face of rapid change. Sustainability of what we do as physicians is really critical. So I'm going to take us to best care, because best care is something I'm particularly proud of. I have the distinct pleasure of being the board chair there, but of working with Dr. Chris Lishka, a respirologist, and Madonna Ferroni, who's the CEO, a COO, and an RT. And it's a physician-led initiative. It's over a decade in the making. It's designed specifically to meet the challenges of chronic disease and health human resources. So imagine even a decade and a half ago, we said, we're going to be in trouble in the future. We're going to be in trouble with chronic disease. And so we embedded interprofessional teams into solo and small family practices. And it allowed really each physician to have a certified respiratory educator, a nurse, or a respiratory technologist, and everybody works at the top of their scope. And the results really speak for themselves. It's an expanded roster capacity for the physician, fewer ER visits, hospitalizations. You were talking about return on investment. It's 4-to-1, and it significantly improved the quality of care. So the qualitative work that we've done with patients has been huge, and with the providers of care. So it doesn't just deliver better outcomes, it really standardizes and scales what Health Quality Ontario guidelines already recommended. So imagine sitting and being part of writing those guidelines to watch them sit on a desk and not get implemented, not with the penetration that we wanted across the board. So this allowed us to do implementation of those guidelines. And it's not just innovation for innovation's sake, really. It's an implementation. It was a thoughtful, compassionate system design. But that took foresight. That took all of us saying, hey, we've got to do something so that a decade and a half later, we've got responses and answers about how to put family physicians on interprofessional teams that aren't parts of these particular payment models like FOS and that are currently in place with FITS. So we weren't reacting to a crisis. We were building resilient, really human-centered models that met future needs. And that was before there was the emergency. That was before everything began to happen. And the scale and spread of that is something that I'm particularly proud of. It's now across most jurisdictions in Ontario and in Canada, BC, Quebec, and New Brunswick. So we're working on that. And I think that's just one example I've had a front row seat to. And I know that physicians have so much innovation, implementation, subject matter expertise that they really want to bring because they know where the puck's going and they want to be part of those decisions. And so I think that allowing a space and a place for that within our membership organization, within our health system, is really going to make a difference. And it's not physicians doing it alone. You heard me say it's family docs with specialists, with RTs, with boards, with, that's also a great example of the collaborative collective impact that we've had.
It is a great example highlighting much of what we've just discussed in this conversation already. If we go back to your the quote, if you want to go fast, go alone. If you want to go far, go together. By doing some of these changes and transformation, we're asking physicians to step outside their comfort zones. So how do you balance respecting physician autonomy with the need for that collective transformation?
Yeah. I think I just want to emphasize acknowledging the fear and the threat sometimes. One of the very fine qualities that physicians have is we are tenacious advocates. And sometimes that's because of the threat or the fear. And I think with autonomy, I just acknowledge the threat and the fear to autonomy to begin with, because it's deeply valued. It's deeply valued. And really, it's part of our social contract with society, right? When we talk about the social contract, and I won't go down that rabbit hole because I could lecture on that for about an hour, but it's what we receive back from society is our autonomy to practice. And it doesn't mean isolation. Autonomy doesn't mean isolation for me. In fact, it, I think, thrives best in systems that support us and systems that, that really leave us working shoulder to shoulder with others rather than alone. So I'll give you a little bit of an example of what I mean by that and how it kind of came to solidify in my own mind was just during the OMA's work on fee modernization. You can imagine those rooms. I heard a lot of concern, a lot of texts, a lot of late night, big, long emails about losing control and losing autonomy. And as I said, that fear is really understandable. And too often it's felt for many that the change that's happening in the system is being done to us, not with us, right? And what we say doesn't matter. And so what we did differently this time in our negotiations, and what I'm really most proud of, is that we brought physicians into the process. And we brought them in as subject matter experts and co-creators, and that they helped to really design the frameworks that they hope to work within. And they weren't handed the outcome and said, endorse this. We're selling you an outcome. They actually shaped it. They actually were involved in doing it. So their autonomy wasn't diminished. It was actually strengthened. And that didn't happen by accident. So part of our work as physician leaders was not just to invite them to the table, but it was to teach them how to engage at the table, how to speak so others would listen, how to advocate for change in a way that really fostered collaboration and made people want to work with them. And instead of a defensiveness and allowing that fear to percolate as a defensiveness. And again, I'll just come back. That's compassionate leadership in action. It's honoring individuals' voices. It's respecting the diversity of opinion, but it's moving forward with a shared purpose. It's finding and aligning around a shared purpose. It's not about giving up independence. And I kind of say to people, it's really, I have an expression, it's about evolving into interdependence and building systems where physicians are really empowered. They're empowered, they're supported, they're truly heard, their voice matters, and we get invited back. I always say, it's one thing to be invited, it's another thing to be invited back, right? And so pay attention to the tables and the people that invite you back. Because that truly means that you're being empowered and your autonomy is being respected, and you matter. Your voice matters.
Absolutely.
So, yeah, I don't think we have to give up autonomy.
It's all in how you define autonomy, and I found that that's an important conversation to have. We go into conversations using words like autonomy, but we may not have a shared meaning or definition of that term. So oftentimes I personally have found it's helpful to start by getting to shared meaning and understanding. Then we can have that conversation, which leads me into my next question, and that's mindset shift. You just talked about helping physicians be part of the collective answer, helping them have a voice in shaping the change. What additional mindset shifts need to happen for physicians to be effective healthcare transformation leaders?
Yeah, I think I kind of summarize it in my own mind as going from me to we. It goes back to the 90s. I can't do it all. If it's me that has to do it all, I'm in a burnout. I'm not going to be effective. So it's a we. And our healthcare systems and just the things we face are way too complex to solve in silos and to solve alone and to feel alone in this. So I just think that our leadership requires more than expertise. I mean, the subject matter expertise and the knowledge and the skills you come to the table with, and I assume you come to the table with because you're so well trained. And I wouldn't begin to understand how to do what you do as a specialist or what you do in your niche and as a physician. But it really, I think the newest skill is the bridge builder. I think it's the big Rolodex. I think it's the networker. It's connecting disciplines. It's connecting communities. It's connecting systems. And the leaders that I've seen create the most meaningful change are the ones who do that. They ask better questions and they build trust across differences. They respect the differences. And I saw the power of this again during COVID. The leadership work in Southwestern Ontario. I remember when your husband, Paul, called me, Dr. Woods called me and said, "Can you lead the non-hospital sector?" And I remember laughing out loud because I thought, well, what is that? That's everything. That's everything outside the hospital. Why don't we call it the hospital, the non-community sector? And he kind of, I don't know if he remembers that, but I was a bit cheeky. But anyway, we had no choice but to collaborate. And we flourished. We had no choice. Every morning at 7 a.m., every leader from every non-hospital organization came on a Zoom call. And I think at first they thought I was a little crazy, but it worked. We built PPE supply chains. We protected our long-term care homes. We launched drive-through primary care clinics. We standardized pediatric care in the community. We ran mass immunization clinics. We shared protocols. We shared collective decision-making. I learned that the CEO of one of our mental health institutions was the best process writer and editor that I could ever have had in my life. And I still have a phenomenal friendship with her over that. And none of that happened because of one leader. Not one of us was in charge. It happened because many of us worked in sync and we respected each other's, what we brought to the table. So it's the we mindset in action. I'm not saying you don't need a conductor. When I'm at the board table, I talk to our board and I say, I'm just here to conduct. I'm not an expert. I'm just here to conduct all of you. And you all have a different instrument that you play, and you can either play like a garage band and be disruptive, sometimes make a little music, sometimes be disruptive, teens in a garage band, or you can be an orchestra, and it's up to us. It's up to us to be whichever one we want to be, and to bring value. So I approach it with that. I think the shift in the mindset has to be that we think from me to we, and it doesn't mean we don't lead. It doesn't mean we give up our autonomy. And I love that shared definition or shared understanding of autonomy. But it doesn't mean we give those things up. It just means collectively we are so much better, and we accomplish so much more.
And it brings me back to if you want to go fast, go alone. If you want to go far, go together. I think what you just demonstrated is a way to go fast and far by together. People often feel it slows us down to go together. And I would argue that it actually speeds us up if we do it based on trust. And then we move at the speed of trust. And you can move very quickly, especially under emergency situations. Wouldn't it be amazing if we could apply that emergency situation thinking to everyday thinking? And so let's use that to shift into the vision forward. If we do these things and physicians embrace this call to lead differently, what does healthcare look like in 5 to 10 years?
Yeah, that's a great question. And that's really what I asked the board of EOMA a few weeks ago. I guess, so for me, what would it look like? If I had a magic wand? More integrated, team-based, person-centered in primary care, but it's deeply embedded in communities and it's designed to meet people where they're at. Physicians will be at the forefront of ethical leadership in technology and shaping how AI, virtual platforms, decision support tools are used to enhance and not replace. A lot of people have used the word augment, enhance, augment, not replace human care. I really, truly don't believe you can. We're going to culture. I want a culture, if I have my magic wand, where there's psychological safety. And I think, again, that needs to be defined. But psychological safety and trust. And you mentioned the importance of trust and relational continuity. Don't burn bridges, build bridges. And I want that to be the norm, not the exception, because we've got lots of pockets of that now. But I want it to be the norm. And physicians would be seen not just as maybe clinical experts, because that's, I think, a really important role that we have. But I want us to be seen as compassionate system architects. So trusted to design care environments that value dignity in patient care and equity. I talk about the soft skills being as important, if not more, than the technical skills, because what I do for a living in ethical remediation, it's the soft skills that get everybody where they come to see me at that stage. And so I think we have to remember to put emphasis on that emotional intelligence and that ability to remain calm and lead with emotional intelligence as much as technical skills. And then, I don't know, I think patients really need to feel seen. I think they need to feel truly seen. I was just at a home this morning where I really didn't need to go. Like, there wasn't any skill that I was taking to that room, but it was empathy. It was allowing patients to be heard. It was, I would say, a dose of doctor at the end of a very long and challenging palliative care case. So I don't think this future's a fantasy. I truly don't. I don't think it's, I think it's possible. I think it's, if we lead differently now, I think it's possible. And I don't think we'll just retain our role. We started by me saying physicians are the most trusted leaders in healthcare. And I think we'll deepen it. I think we'll deepen that trust. I think we'll elevate that trust if we're able to change and lead differently now.
I appreciate how you said that physicians are the most trusted leaders in healthcare. That also, the data would show that physicians are one of the most trusted professions as well. And yes, I think it's really important that we continue to foster and sustain that trust. And because of the burnout epidemic, we've seen that loss of compassion, because burnout is compassion fatigue. So I think the funny thing is, compassion fatigue is a symptom of burnout, but demonstrating compassion is also the cure for burnout. So it's a
absolutely
funny conundrum, and I'm so glad that you led with that.
It is a funny conundrum, isn't it? I always, at the end of a challenging palliative care case, because I did obstetrics for the first 15 years, and everybody gets excited about the babies coming into the world. But now we're getting less death averse and we're helping people die. But I always say I learn way more than I give. Way more than I give. I get way more than I give, and it fills my cup. And so I think, yes, we have to remember that giving is in fact a solution and a benefit to prevent burnout. And I think it's through the relationships that you make and you foster.
Yes.
Yeah.
So Cathy, as we think about closing, I like to, as a coach, and you'll appreciate this because you coach too, we like to look at one action step that's going to be different because of our conversation. So, what's one thing you would hope physicians will do differently tomorrow as a result of this conversation we're having today?
Yeah, I think can I have two?
Yes. Yes. There you go. Pushing the limit again.
I'm pushing the limit. I'd like to. The first one is to not fear or feel threatened regarding autonomy. I think I can't say that enough. You will not become irrelevant. You will not become irrelevant. And so I could go on and on about that, but I really think that's a critical thing for people to hold. The second thing is that I want physicians to be culture shapers. I don't know if that's even a word but culture shapers. So not only do I want you to be an architect, but I want you to be a culture shaper, because every interaction that you have, whether it's on a ward, in a hospital, in a hallway, in a Zoom meeting, it's an opportunity to shape the culture of medicine. And it's not always about taking on formal leadership roles. It's about how we treat each other every day, how we show up, how we carry ourselves when no one's watching. That's our professionalism. And we're the most trusted profession, as you've said. So how we create a space when we speak to others, how we respond when they do. So I'd really, ask yourself some questions. How can I shape the culture? How do I show up? What tone am I setting by what I'm saying? Whose voice isn't being heard right now? Am I speaking in a way that people can actually listen to me, or are they thrown off and just want to get out of the room as quickly as they can? And how can I model the type of system that I really want to work in? If the system's broken for you, how can you model what you want it to look like? So I think that's kind of I kind of put that under culture shaper, right? And professionalism. So the system doesn't, yes, we need more clinical experts in numbers, but we need more physicians who embody compassion in every place they touch, in every corridor, every conversation, and every decision. And that's how we build a better system. And it's one person at a time. Mother Teresa said one drop in the ocean changes the ocean, and I truly believe that. It's the first person starts, it's the second person, it's getting invited back, and it's the second and third person dancing with the first person who starts dancing that makes a dance happen. So meaningful change doesn't start with structure. I'm a big believer in that. It starts with people, and it can start with you. It can start with one physician making a difference.
So beautifully said. Well, Dr. Cathy Faulds, thank you for sharing your powerful vision and challenging all of us, physicians and healthcare leaders alike, to step up with courage and foresight. Your call for physicians to lead transformation and be culture shapers rather than simply reacting to it is exactly the kind of bold thinking that our health system needs right now. To our listeners, Dr. Faulds has given us a roadmap. So embrace that collective impact, lead with compassion and intention, and have the courage to question the status quo. The future of healthcare depends not on maintaining what's comfortable, but on leaders and physicians like you taking that brave step forward to create the system patients deserve. Remember, as Cathy reminds us, you don't have to transform the entire system overnight. You can start by leading differently in your own sphere of influence. That's where change really begins. It's stochastic, I think is what I heard Cathy describe. So thank you for joining us on the pod. If today's conversation inspired you as a listener out there to think differently about your role in healthcare transformation, please share this episode with a colleague who needs to hear this message. Together, we can support more women leaders and physician leaders in healthcare and create the change to our profession, or the change to the system and that our profession desperately needs. So until next time, keep leading with courage.
Thank you so much. It's been a privilege to chat with you this morning. Take care.
The privilege has been mine. Thank you. Thank you for listening to today's episode of the pod. I invite you to join our pod every month as we empower one another, fostering a world where women in healthcare leadership thrive.